Welcome to Deep Dive Ortho, the show dedicated to unpacking complex musculoskeletal challenges to give you that cutting-edge understanding. Today, we're tackling a scenario that I suspect many of you, as medical professionals, have faced: the wrist injury that just doesn't quite fit the standard diagnostic picture, leading to persistent pain and a frustratingly elusive answer. How often have you encountered a patient with ongoing wrist discomfort where routine imaging simply falls short, leaving you to piece together a puzzle with missing parts?
It's remarkably common frustration, isn't it? Our initial instincts often lead us to look for the usual suspects, like scaphoid fractures, and, well, rightly so. But the carpus is a wonderfully intricate structure, and some of its smaller, more elusive inhabitants can conceal significant injuries with truly profound clinical implications. These are the ones that can trip us up.
That's precisely the challenge we're diving into today. Our mission is to equip you with a comprehensive, actionable understanding of these less common, yet clinically incredibly significant carpal fractures. We're moving beyond the scaphoid to meticulously explore their mechanisms of injury, the often frustrating diagnostic hurdles we face, and the tailored treatment strategies that are absolutely crucial. Crucial for preventing long-term complications and ensuring optimal patient outcomes, particularly for our active and athletic patients. And to kick us off, we're going to start with a tiny bone that often causes disproportionately big problems: the pisiform.
Fantastic starting point. The pisiform, often aptly described as a small, knobbly, pea-shaped sesamoid bone, is indeed quite unique. Its sesamoid nature means it's not a true carpal bone in the conventional sense, as it's actually embedded directly within a tendon specifically, the flexor carpius noris, or FCU, tendon. This embedding gives it a rather distinct anatomical position and, well, a very specific functional role.
And its location, as you touched upon, is genuinely key, isn't it? It holds a peculiar spot, being the most ulnar and palmar carpal bone within the proximal row. But what's truly fascinating is its singular articulation. It articulates solely with the triquetral bone. It also sits on a plane that's distinctly anterior to all the other carpal bones, almost like it's guarding the front of the wrist.
That's right. Its strategic anterior and ulnar position makes it a critical attachment point and provides a mechanical advantage.
Yeah.
The FCU muscle, which is a powerful wrist flexor, uses the pisiform as a fulcrum. Think of it much like the patella does for the quadriceps tendon in the knee. It lengthens the lever arm of the tendon, allowing for far more efficient wrist flexion and ulnar deviation. Beyond the FCU, the pisiform also serves as an attachment point for the abductor digiti minimi muscle and is a vital component of the transverse carpal ligament, famously forming the radial wall of Guyon's canal. This anatomical proximity to Guyon's canal is incredibly significant, as we know that canal houses the ulnar nerve and artery, making the pisiform a direct neighbor to critical neurovascular structures.
That patella analogy really clarifies its mechanical advantage. It's a small bone, but it pulls a lot of weight, literally. And it's not just its current function that's intriguing, but its evolutionary story too. When we look at the human pisiform, it's notably shorter compared to those found in other primates. This has led researchers to suggest it might be the result of a lost growth plate, potentially influenced by complex genetic signaling, specifically HOCOR gene expression. This connection links its development not just to forearm length, but even speculatively to the evolution of tool use or our unique capacity for throwing. A small bone, certainly, but one with a surprisingly large historical and functional narrative.
It's a remarkable example of how even minor anatomical variations can reflect significant functional shifts over evolutionary time. Now, despite its rather prominent position at the base of the hypothenar eminence, easily palpable for us, pisiform fractures are actually quite rare. They typically account for approximately 1% to 2% of all carpal fractures, though you'll find reports citing figures as low as 0.2% and perhaps as high as 2%. This rarity, unfortunately, is a significant factor in why they are so frequently missed on initial presentation. The key insight here is, never underestimate a tiny bone. Its fracture can be a diagnostic red herring if you're not specifically looking for it.
That low incidence makes a high index of suspicion absolutely paramount then. So when they do occur, what are the most common injury mechanisms we should be thinking about? What kind of patient history should prompt us as clinicians to consider a pisiform fracture?
Well, the overwhelming majority of pisiform fractures result from a direct impact to the palm. Imagine a patient falling directly onto an outstretched hand, perhaps during a slip or a sports injury, with the impact directly over the hypothenar eminence. We also see this in specific athletic activities, such as direct impacts during racket sports, or even the recoil force experienced when firing a handgun, for example. Another distinct mechanism involves avulsion fractures. These typically present as a transverse fracture pattern, They arise from a powerful sudden pull of the FCU tendon during resisted hyperextension of the wrist. It's somewhat similar to how a direct blow to the patella might cause a comminuted fracture, whereas a strong pull from the patellar tendon results in a transverse avulsion fracture. It's also critical to note that roughly half of pisiform fractures occur in isolation, meaning they are the only injury. However, the other halves are associated with other carpal fractures or even distal radius fractures. This association can further complicate the initial diagnosis, as attention might be drawn to the more obvious concurrent injury. And whilst less common than fractures, pisiform dislocations can also occur from blunt trauma and forceful falls onto an outstretched wrist, again highlighting the vulnerability of this small bone.
That overlap with other, perhaps more obvious injuries truly makes a heightened level of vigilance essential. So, a patient walks into our clinic with a potential pisiform injury. What are the key clinical signs we're actively looking for? And what specific examination techniques should we be employing to pinpoint this subtle injury?
The primary indicators you'll likely observe are highly localized pain and swelling, specifically concentrated on the palmar and ulnar side of the wrist. Patients will often describe this pain as quite sharp or aching, especially with movement. They might also spontaneously complain of grip weakness, which can be a significant functional impairment. On examination, the most revealing finding is usually exquisite point tenderness directly over the pisiform bone itself. To elicit this, you gently palpate the area just distal to the ulnar styloid, on the palmar aspect. You can also elicit pain during what we call a shuck maneuver of the pisiform. This involves gently grasping the pisiform between your thumb and forefinger and attempting to move it subtly from side to side, noting any crepitus or increased pain. Additionally, pain will typically be provoked with resisted wrist flexion, as this engages the FCU tendon that inserts onto the pisiform.
Right. And given its close anatomical relationship with Guyon's canal and the critical structures it houses, I imagine a thorough neurovascular assessment is absolutely paramount in these cases, isn't it?
Absolutely critical. Documenting the ulnar nerve function thoroughly is, well, it's non-negotiable. If the nerve is affected, even subtly, you might observe altered sensations such as numbness or tingling in the little finger and the ulnar half of the ring finger. More significantly, you could detect motor weakness in the intrinsic muscles supplied by the ulnar nerve, impacting hand function. This meticulous assessment is vital for differentiating pure bony or soft tissue pain from potential nerve involvement, and it profoundly influences your subsequent management decisions.
Okay, now this is where it gets really interesting and often frustrating for clinicians because standard imaging can be quite misleading. Why do routine anteroposterior and lateral radiographs so frequently miss pisiform fractures? What makes them so elusive on a typical X-ray?
The challenge primarily stems from the superimposition of overlying bone structures. Because the pisiform sits in such an anterior plane relative to the other carpal bones, it can be easily obscured or silhouetted on conventional AP and lateral views. It's a bit like trying to spot a specific pebble at the bottom of a pond when other rocks are layered on top. This optical illusion means that even a significant fracture can appear deceptively normal. This is precisely why relying solely on conventional views for suspected pisiform injuries is a common pitfall. To overcome this, specialized radiographic views are absolutely essential. The carpal tunnel view is particularly effective here. It's a tangential projection that clearly demonstrates the pisiform. And, as a bonus, it also offers a reproducible profile of the hamate hook, which we'll touch on later. Another crucial view is the reverse oblique view, which involves placing the wrist in approximately 30 degrees of supination. This maneuver brings the pisiform clearly into profile, effectively isolating it from overlying structures and allowing for a much clearer assessment.
So we're not just looking for the fracture itself, but also for any associated pisotriquetral joint injury. What specific radiographic findings should immediately raise our suspicion for damage to that articulation?
Yes, you should be keenly alert to two key findings. Firstly, any joint separation between the pisiform and triquetrum that measures greater than 3 millimeters. This suggests a significant disruption. Secondly, if the bone surfaces of the pisiform and triquetrum deviate more than 20 degrees from being parallel, both of these indicators point strongly towards potential instability or frank damage within that critical pisitriquetral articulation. When plain radiographs yield an equivocal result, or if your clinical suspicion remains high despite negative X-rays, that's when advanced imaging modalities become not just helpful but absolutely warranted. A CT scan, for instance, is invaluable for precisely delineating fracture patterns, identifying truly occult fractures that plain films simply cannot pick up. And it's particularly useful in patients presenting with chronic pain after trauma where a subtle fracture might be the underlying cause. MRI, on the other hand, is generally indicated when there's a strong clinical suspicion of a carpal fracture, but radiographs are completely negative.
MRI excels at showing bone marrow edema, which is an early and sensitive indicator of a fracture even before it's visible on X-ray. And it provides a far clearer view of the surrounding soft tissues and ligaments, allowing us to rule out or identify concomitant ligamentous injuries.
Okay, so we've navigated the diagnostic challenges and arrived at a diagnosis. Let's now unpack the treatment pathways. What's the first line of management for these pisiform fractures? Is it always conservative?
For many pisiform fractures, non-operative management is indeed the first line, and often highly successful. This approach is most appropriate for acute, non-displaced fractures, or for those smaller avulsion-type fractures where the bone fragments haven't significantly separated. This is particularly suitable when the time lost from training or participation isn't critically time-sensitive for the patient, for example, a recreational athlete compared to a professional in mid-season. The standard technique typically involves immobilization in a short-arm cast or splint, usually for a period of 4 to 6 weeks. Some protocols might even extend this to 6 to 8 weeks, often with the wrist positioned in about 30 degrees of flexion and slight ulnar deviation, which helps to relax the SCU tendon. The good news here is that the vast majority of these non-displaced fractures are reported to heal well and critically without the development of post-traumatic osteoarthritis.
That's reassuring for those patients. But what about when conservative measures aren't sufficient? Or when the fracture is more severe, perhaps displaced or causing persistent symptoms? When do we shift our thinking towards operative management? And specifically, when do we consider a pisiformectomy, which is the excision of the bone?
Right. Pisiformectomy is indeed a key surgical option and is often considered the optimal treatment for severely displaced and symptomatic fractures. Also for painful non-unions where the bone hasn't healed, or for chronic pisotriquetral arthritis that's causing persistent discomfort. For high-level athletes, particularly those aiming for the earliest possible return to sport, pisiformectomy is frequently the preferred option because of its generally quicker recovery profile compared to potential internal fixation. It's also indicated when a fracture presents with clear evidence of decreased FCU function, suggesting that the mechanical advantage of the pisiform has been compromised.
Can you walk us through the surgical approach for a pisiformectomy? What are the critical anatomical considerations we need to keep in mind, particularly regarding the nearby neurovascular structures?
Certainly. The preferred surgical approach for a pisiformectomy involves an anterior curvilinear incision, which we typically center over the hamate hook, extending proximally towards the pisiform. A crucial step during this procedure is the careful mobilization and retraction of the ulnar nerve. We meticulously protect and retract it towards the radial side of the palm, away from our surgical field because, as we discussed, the pisiform forms a key part of Guillaume's canal, and the ulnar nerve is immediately adjacent. This careful nerve protection is paramount to avoid iatrogenic injury. We also typically caution against extending the incision directly across the wrist crease. Anecdotal experience suggests that scars positioned directly over the wrist crease tend to remain more sensitive and can be prone to irritation for a much longer period. Whilst a lateral approach has been described in some literature, it often necessitates a blind release of the radial attachments of the pisiform, which means a less direct view of the critical structures. So the anterior approach is generally preferred for its superior nerve visualization and overall safety profile.
And once the pisiformectomy has been performed, what are the expected outcomes for patients? Does removing such a functionally important bone significantly impair wrist function long term?
That's a very valid question. Studies consistently indicate that pisiformectomy is a highly reliable way to relieve pain associated with these specific pathologies. Furthermore, it generally does not significantly impair overall wrist function. While some studies have noted very slight, often subclinical, impairment in terminal wrist extension, or perhaps a minor reduction in strength during heavy lifting and very strenuous weight-bearing activities. Patients typically do not report changes in their occupation or their general activity level. This speaks volumes about the procedure's functional efficacy and high patient satisfaction. They regain a pain-free, functional wrist, which is the ultimate goal.
That's certainly reassuring for both clinicians and patients. Now, what about internal fixation? When is that considered a viable option, and what are its particular advantages, especially given the discussion about Guillaume's canal?
Internal fixation is typically discussed for displaced and particularly open fractures where the bone fragments are sufficiently large and robust enough to be fixed with hardware. For instance, case studies have demonstrated successful union and excellent functional recovery using internal fixation with small cortical screws and circlage wiring. The primary and very significant advantage of internal fixation compared to pisiform excision is that it aims to preserve the pisiform bone itself. This preservation avoids leaving the ulnar nerve and artery directly exposed to potential direct trauma in the postoperative period. This approach can, therefore, potentially prevent rare but serious complications such as Hammer syndrome, that's a condition characterized by ulnar artery thrombosis, often linked to repetitive hand trauma or persistent neuropathy due to direct nerve irritation. It's really about protecting those vital structures by keeping the anatomical barrier intact.
And what does the post-operative regimen typically look like for a patient who's undergone internal fixation for a pisiform fracture?
Following internal fixation, the typical follow-up protocol involves initial immobilization. We usually split the wrist in a position of slight flexion and ulnar deviation, generally for about 4 weeks. After this initial period, we transition the patient to a neutral wrist position, maintaining immobilization for another 4 weeks, bringing the total immobilization period to around 8 weeks. Once the hardware is stable and healing is progressing, physiotherapy becomes vitally important. It's a structured, progressive program aimed at regaining full wrist and hand strength, restoring range of motion, and gradually reintroducing functional activities to ensure a complete and robust recovery.
So, Professor, what are the main complications that we as clinicians need to be most vigilant about when managing pisiform fractures? What are the red flags we should be looking for?
Well, the most common complication by far, and one that we must consistently guard against, is misdiagnosis or a delayed diagnosis. This often stems from the rarity of the injury and the diagnostic challenges we've just discussed. Unfortunately, a delayed or missed diagnosis can lead to truly disabling long-term sequelae for the patient. If a pisiform fracture is not adequately addressed in a timely manner, it can result in a painful non-union or malunion, where the bone heals in a suboptimal position. Clinically, this presents as chronic wrist pain, persistent grip weakness, or significantly restricted wrist movements, and these chronic symptoms frequently necessitate surgical excision of the pisiform down the line. Chronic ulnar-sided pain is a persistent issue if the fracture is not properly managed from the outset.
And then there's ulnar nerve dysfunction, which we touched upon earlier. How does that typically present as a complication, and what's the management protocol there?
Yes, ulnar nerve dysfunction is a crucial consideration. At the time of injury, any associated nerve symptoms are often neuropraxias. That means a temporary disruption of nerve conduction without structural damage. These usually tend to resolve spontaneously with observation over a period of 8 to 12 weeks. However, meticulous and cautious monitoring throughout this period is absolutely essential. If nerve deficits persist beyond 12 weeks, or more critically, if they worsen at any point during the treatment phase, nerve exploration with concurrent pisiformectomy is strongly recommended. This allows us to directly visualize the nerve, address any compression or irritation, and remove the problematic bone fragment. Furthermore, if for any reason the ulnar nerve was not adequately visualized and protected during a previous surgical intervention, and the patient subsequently develops significant nerve deficits, immediate surgical exploration is advised to prevent any potential permanent damage to the nerve.
Okay, that was a truly comprehensive deep dive into the pisiform. We've deconstructed its anatomy, its peculiar injury patterns, and the critical diagnostic and treatment nuances. Now, with that heightened index of suspicion firmly in mind, let's take that understanding and apply it to a quick scan of some of the other less common carpal fractures, moving beyond the ubiquitous scaphoid. We won't delve into the same granular detail, but we'll focus on the essential clinical pearls for your practice. Let's start with the triquetral fractures, which, perhaps surprisingly to some, actually rank as the second most common carpal fracture after the scaphoid.
Indeed, triquetral fractures constitute about 3% to 5% of all carpal fractures. We primarily identify two distinct patterns. There are the very common dorsal chip fractures, which can account for up to 93% of all triquetral fractures. These are typically small avulsions from the dorsal aspect. And then, in contrast, the less common triquetral body fractures typically result from much higher energy injuries.
And the mechanisms behind these two types of triquetral injuries, what should we look for in the patient history?
Dorsal chip fractures often occur when the wrist is subjected to extreme palmar flexion combined with radial deviation. This mechanism can cause an avulsion of a small bone fragment from the attachment of the strong radiotriquetral and tricuspid ligaments. Another common scenario involves a fall onto an ulnarly deviated wrist in dorsiflexion, where the ulnar styloid essentially acts as a chisel, impinging on and shearing off a piece of the dorsal cortex of the triquetrum. Triquetral body fractures, as mentioned, are indicators of high-energy trauma. They are frequently associated with greater arc perineate fracture dislocations, occurring in anywhere from 12% to 25% of these complex wrist injuries. They can also present concurrently with other fractures of the hamate, distal ulna, or distal radius, so a thorough assessment is crucial.
Diagnosing these sounds challenging, particularly given the proximity of the triangular fibrocartilage complex, or TFCC. How do we best approach diagnosis?
You're right, it can be tricky. Eliciting pinpoint tenderness solely over the trochanterium can be difficult acutely due to the overlying TFCC. Instead, pain with wrist flexion and extension is often a more reliable indicator, particularly for those dorsal avulsion injuries. Whilst many trochanterial fractures can be visualized on standard AP, lateral, and 45-degree pronated oblique radiographs, a CT scan is frequently helpful for identifying occult trochanterial fractures that might be missed on plain films, especially if clinical suspicion remains high despite negative X-rays.
And the treatment approach for these cricketal fractures?
For the common dorsal chip fractures, which frequently go on to an asymptomatic fibrous union, our primary focus is often on managing the associated soft tissue injury. This typically involves immobilization with a short arm cast for a period of 3 to 6 weeks to allow for soft tissue healing. If there's significant swelling or persistent pain, an MRI should be considered to rule out concomitant ligamentous injuries, especially to the TFCC. Symptomatic fragments that continue to cause pain despite conservative measures can be excised. For the rarer, displaced trochanterial body fractures, pinning the lunotriquetral ligament is often employed to restore stability, and open reduction and internal fixation has been described in rare, complex instances. The most common complication, much like the pisiform, is misdiagnosis or delayed diagnosis, which can lead to persistent pain.
Right. From the trochanterial, our attention turns to the hamate, a bone whose unique anatomy often impacts a particular group of patients, making up about 2% of carpal fractures. This one always makes me think of athletes, especially golfers and baseball players.
You're spot on. The hamate hook's distinct anatomy places it at significant risk from direct compressive forces, such as striking the palm, and particularly from shear forces generated by the adjacent flexor tendons during forceful wrist torque. This is precisely why we commonly see these injuries in sports like tennis, baseball batting, where the bat handle impacts the palm in golf, especially when a player hits fat and drives the club into the ground. In batters and golfers, it's typically the non-dominant hand that's at risk, whereas in racket sports, it's usually the dominant hand that's affected. The hamatate also plays a crucial role in forming the radial border of Guyon's canal and the ulnar border of the carpal tunnel, placing both the median and ulnar nerves at risk, though median nerve symptoms are less common in isolated hamate fractures. Hamate body fractures, in contrast, generally result from much higher energy axial loads transmitted through the fourth and fifth metacarpals, often leading to complex carpometacarpal fracture dislocations.
What's the classic clinical picture for a hamate hook fracture then? What are the telltale signs for a clinician?
Patients typically present with quite localized pain in the ulnar palm, which is often significantly aggravated by active grasp or gripping activities. Point tenderness is elicited directly over the hamate hook, which you can typically palpate about 2 centimeters distal to the pisiform, deep in the hypothenar eminence. Acutely, you might even observe transient ulnar nerve paresthesias, such as tingling or numbness. In more delayed presentations, the symptoms often become vague. Persistent ulnar-sided wrist and hand pain, sometimes with subtle median or ulnar nerve symptoms, and often a noticeable reduction in grip strength. A very specific diagnostic maneuver involves eliciting pain with resisted ring and small finger flexion. This pain will often be worsened by ulnar deviation and lessened with radial deviation. This maneuver can help uncover an occult hamate hook injury that is irritating the flexor tendons. It's absolutely crucial to consider a hamate hook fracture, even if initial imaging appears normal, particularly if flexor tendinitis of the ring or small fingers is present, because an untreated sharp fracture fragment can lead to partial or even complete rupture of these tendons, which is a devastating complication.
And given its often subtle presentation, what are the specific imaging challenges and solutions for hamate fractures?
The radiographic findings on standard views are notoriously subtle. On a normal PA radiograph, you'll see an oblique articular space between the hamate and the base of the fourth and fifth metacarpals. This space will be lost with a CMC dislocation and an anterior hamate shear fracture. A normal PA also shows a circular density at the distal hamate, which is an end-on view of the hook. This circle is lost or appears chlorotic with a displaced fracture or a non-displaced non-union. This requires a very keen eye. To overcome these limitations, spiralized views are crucial. The carpal tunnel view, or a supinated oblique view with wrist dorsiflexion, are excellent. However, a CT scan, particularly with the hands positioned in a praying fashion to optimize the view, has shown superior detection rates for occult hamate fractures. It's also invaluable for excluding congenital variations, such as an os hamate proprium. So if your suspicion is high, a CT is really your best friend.
What are the treatment pathways for hamate fractures, and what should we be mindful of regarding complications?
For displaced hamate body fractures, the best practice is typically operative reduction and internal fixation, often utilizing mini-fragment screws to achieve stable reduction. For hamate hook fractures, whilst non-operative management with immobilization can occasionally be successful for truly non-displaced fractures diagnosed within the first week, the results are far less favorable for delayed diagnoses or displaced fractures. In practical terms, especially for athletes seeking the earliest possible return to sport, excision of acute hamate hook fractures is often considered the optimal treatment. The surgical exposure is usually through a curvilinear incision centered over the hamate hook, requiring meticulous care to mobilize and protect the motor branch of the ulnar nerve to avoid iatrogenic injury. Complete removal of the hook, even if the fracture fragment is relatively small and anterior, is generally preferred to prevent ongoing flexor tendon irritation. Now, regarding complications, these can be significant. The most concerning is rupture or fraying of the flexor digitorum profundus and superficialis tendons to the ring and small fingers. That's been reported in approximately 14% of cases, often due to chronic irritation from an irregular fracture surface. Osteonecrosis of the hamate hook has also been reported, attributed to its somewhat precarious watershed area of vascularization. Overall, a 3% complication rate is associated with excision, with nerve injury being the most common untoward event, underscoring the importance of careful surgical technique.
Moving on, trapezium fractures make up about 4% to 5% of carpal fractures. These seem to have a strong association with other, often high-energy injuries. What makes them unique?
They certainly do. Fractures of the trapezium body are the most common pattern we see, particularly sagittal split fractures, which divide the bone longitudinally. Volar trapezial ridge fractures, where the transverse carpal ligament attaches, are less frequent. Given its relatively protected position within the carpus, many trapezium fractures are indeed the result of high-energy injuries, such as motor vehicle accidents or direct falls onto an outstretched hand, where a significant axial load drives the first metacarpal into the trapezium. This high-energy mechanism often means they are frequently associated with other injuries, specifically first metacarpal fractures, and sometimes with concomitant scaphoid, distal radius, or even hamate fractures. So when you see a high-energy wrist injury, always broaden your search.
What are the key clinical findings that should point us towards a trapezium fracture?
The primary acute sign is exquisite point tenderness at the volar base of the thumb, specifically just distal to the scaphoid's volar tubercle. Patients will also complain of painful and significantly weakened pinch strength, a fundamental hand function. Furthermore, pain is often exacerbated with wrist flexion, which we attribute to the close proximity of the flexor carpi radialis tendon to the longitudinal groove on the trapezium, which can become inflamed or irritated with a fracture.
And how do we image these effectively given their complex anatomy at the base of the thumb?
Whilst standard hand views can often reveal trapezium body fractures, they are not always sufficient. For a clearer view of the critical trapezio-metacarpal articulation, we often rely on a specialized projection called Betz view. This is a pronated anterior-posterior view that optimizes the joint space. For suspected trapezial ridge fractures, the carpal canal view is paramount as it best demonstrates these smaller volar fragments. In chronic cases, or when trying to identify occult ridge fractures or subtle coronal plane body fractures, a CT scan is an invaluable diagnostic tool, offering superior detail.
What are the treatment considerations for trapezium fractures, both conservative and operative?
Non-displaced trapezial body fractures can often be managed non-operatively with immobilization and a thumb spica cast or splint for 4 to 6 weeks, allowing for bone healing. However, for interarticular fractures that are displaced by 2 millimeters or more, open reduction and internal fixation is generally the preferred approach. This is often performed via a Wagner approach, which is a specific surgical incision that provides excellent access to the joint to precisely reduce the fragments and minimize residual deformity, thereby preventing long-term post-traumatic arthritis. For type 2 ridge fractures, where the fragment is typically pulled by the transverse carpal ligament, excision of the fragment is generally recommended due to a high rate of non-union if simply immobilized, as the ligament's pull prevents effective healing. In terms of complications, these can include irritation of the median nerve or the flexor carpi radialis tendon due to their proximity. Post-traumatic arthritis is a common radiographic finding after body fractures, though it's important to note that it can often be asymptomatic for the patient, meaning it might show up on an X-ray but not cause significant pain or functional limitation.
Let's turn to capitate fractures, which are also relatively rare. At 1% to 2% of carpal fractures, they sound quite severe given their strong association with high-energy mechanisms.
That's absolutely right. The capitate is centrally located and well protected by the surrounding carpal bones, so high-energy trauma is almost always required to fracture it. In a notable study, capitate fractures occurred 4 times more commonly as part of a complex paralunate fracture dislocation than as an isolated injury. A very specific and challenging combination is the scaphoid waist fracture coupled with a capitate fracture exhibiting malrotation of the proximal fragment. This is known as the naviculocapitate or scaphocapitate fracture syndrome. The transcaphoid transcapitate paralunate fracture dislocation is the most common and arguably the most devastating pattern we see involving the capitate.
What specific mechanisms are thought to cause these capitate injuries, particularly these combined patterns?
While isolated capitate fractures are generally believed to result from either a direct blow to the wrist or an indirect axial load transmitted through the third metacarpal with the wrist in a flexed position. This often leads to a fracture at the capitate neck and occasionally at the base of the third metacarpal. For the complex combined injuries, such as the transcaphoid, transcapitate paralunate fracture dislocation, the mechanism is typically severe wrist hyperextension combined with radial deviation. This mechanism is thought to drive the radial styloid into the scaphoid, causing it to fracture. Another proposed mechanism suggests that the dorsal lip of the distal radius forcefully strikes the dorsal capitate, which can then result in the unattached proximal pole fragment of the capitate flipping a remarkable 180 degrees. This rotational instability is critical.
So, a high index of suspicion is paramount for diagnosis, especially given their protected position. How do we approach their identification?
Absolutely. Due to its central protected position, careful and precise palpation to localize dorsal tenderness directly over the capitate is the key clinical sign. Whilst standard radiographs can sometimes elucidate capitate fractures, especially on oblique views, coronal plane fractures, those running front to back, are much better visualized and defined with a CT scan or MRI. MRI can also be invaluable for assessing damage to the surrounding ligaments, though in practice, if surgical treatment via a dorsal approach is planned, MRI is less frequently used preoperatively, as the direct surgical exposure allows for a thorough inspection of both intercarpal and extrinsic ligaments.
And the treatment strategy for these often complex capitate fractures?
Non-operative treatment should only be considered for truly non-displaced neck fractures, and only with extreme caution. Cast or splint immobilization should be continued until there are clear radiographic and clinical signs of complete healing, often confirmed by a CT scan demonstrating bridging trabeculae across the fracture site. For all other capitate fractures, particularly displaced ones, open reduction and internal fixation with pins or compression screws is the gold standard, typically performed through a dorsal incision. The prognosis for capitate fractures varies significantly depending on the extent of soft tissue and articular surface involvement, and crucially whether the head fragment maintains its viability or develops a vascular necrosis.
A vascular necrosis. That's a very significant concern here, isn't it? Much like the scaphoid, the capitate seems particularly vulnerable.
It is indeed. The capitate possesses a relatively tenuous retrograde blood supply, meaning its blood flow often comes from the distal end back towards the proximal pole. This places the proximal pole at a high risk for a vascular necrosis, especially with mid-level fractures that disrupt this critical blood supply. The statistics are quite stark. Non-union of isolated capitate fractures occurs in over 50% of cases, if not managed appropriately. Stiffness of the wrist and midcarpal arthritis are common long-term consequences, and for high-level athletes, these injuries can very often be season-ending, if not, sadly, career-ending. This highlights the severe impact of even a seemingly small fracture in such a critical anatomical location.
The trapezoid fracture, less than 1% of carpal fractures, is next on our list. What makes them so rare, and how do they typically present clinically?
Their extreme rarity stems directly from their anatomical position. The trapezoid is incredibly well protected, nestled securely between surrounding carpal bones. Like the capitate, a trapezoid fracture typically requires a very high-energy injury mechanism. The trapezoid itself has a unique keystone shape, with its dorsal surface being roughly twice the size of its volar side. This shape, combined with the fact that its volar ligaments are generally stronger than its dorsal ones, predisposes the trapezoid to dorsal dislocation. The most common mechanism for this is an axial force transmitted through a flexed second metacarpal, which then causes this characteristic dorsal displacement of the trapezoid.
And how do we diagnose these subtle, rare injuries?
Clinically, you'll find exquisite point tenderness at the base of the index metacarpal, often accompanied by pain with motion and occasionally a visible deformity if a dislocation is present. Pain can also be elicited with even gentle motion of the second metacarpal. On imaging, standard AP, lateral, and oblique radiographs can sometimes detect isolated dislocations, but fracture dislocations are best visualized on the AP view. On the AP view, a dislocated trapezoid will allow proximal migration of the second metacarpal, obscuring the normal joint space. Critically, a CT scan is indispensable for identifying occult fractures, particularly in patients presenting with chronic pain where the initial plain films were inconclusive.
What are the treatment strategies for trapezoid fractures, and are there any specific contraindications?
For dorsal dislocations of the trapezoid, a closed reduction is typically performed using longitudinal traction, followed by palmar flexion of the wrist and direct dorsal pressure on the trapezoid to push it back into place. If the reduction proves unstable, percutaneous pin fixation, where pins are inserted through the skin, is often sufficient to maintain stability. Unstable or irreducible dislocations, or those with significant joint incongruity, are best treated with open reduction and either pin or screw fixation to achieve an anatomical reduction. It's crucially important to note that trapezoid excision in a fracture or dislocation is strictly contraindicated. Why? Because it leads to unavoidable and significant proximal migration of the index metacarpal, which severely impairs hand function. Any hardware used is typically left in place for 6 to 8 weeks, with unrestricted use of the hand generally permitted by 12 weeks. Complications to be aware of include a significant risk of avascular necrosis due to disruption of the dorsal blood supply, which accounts for approximately 70% of the trapezoid's interosseous blood supply.
If symptomatic malunions or non-unions develop, they can often be effectively treated by arthrodesis, which is a surgical fusion of the carpometacarpal joint.
Finally, we turn our attention to lunate fractures, another rare one, making up only about 1% of carpal fractures. How do these typically present, and what distinguishes them?
Acute lunate fractures are indeed uncommon. We classify them into 5 main subtypes based on their vascularity and precise location: volar pole, dorsal pole, transverse body, sagittal body, and osteochondral or chip fractures. Of these, the volar pole fracture is the most common. The lunate itself is typically compressed between the distal radius and the capitate during extreme wrist hyperextension and ulnar deviation, such as occurs during a forceful fall on an outstretched hand. In sports, these injuries have been described after a direct, high-impact blow to the hand by a ball, especially if it's delivered directly in line with the forearm.
And their presentation and diagnosis?
Clinically, tenderness directly over the dorsal aspect of the lunate should immediately raise your suspicion. Pain is often markedly accentuated by wrist motion, particularly extension. Standard radiographs can, unfortunately, miss smaller or non-displaced fractures due to the overlying bones. Therefore, a CT scan or MRI is absolutely indicated if your clinical examination strongly suggests an occult fracture or, equally importantly, a ligamentous injury that might be masking the underlying lunate issue.
How do we approach the treatment of lunate fractures? Is it always a surgical intervention?
Treatment of lunate fractures often mirrors that of tricuspidal fractures. Small marginal chip fractures, which are often incidental findings from old, unrecognized injuries, are typically managed with short courses of immobilization, followed by a careful re-examination to ensure stability. However, if you observe any malalignment of the capitate over the lunate, or a scapholunate diastasis, a widening of the joint space between the scaphoid and lunate, this is a clear indication of carpal instability. Similarly, the presence of a volar intercalated segment instability, or VISI, deformity with a palmar chip fracture, or a dorsal intercalated segment instability, DISI, deformity with a dorsal chip, necessitates operative fixation to restore carpal alignment and prevent long-term complications. It's often worthwhile obtaining contralateral wrist views, especially in women presenting with a VISI pattern, as this can, in some cases, be a normal anatomical variant. For volar pole fractures, which are often quite small, they may not be amenable to fixation with a standard headless screw.
In these cases, they can sometimes be secured with a buried pin and a wire suture looped around the scapholunate ligament to provide stability. Fractures that extend into the main body of the lunate and involve the articular surface are best characterized by a CT scan and frequently require a dorsal approach for precise reduction and internal fixation. For comminuted fractures, cancellous bone grafting might be necessary to fill defects, and the entire construct may be protected by a spanning external fixator to ensure adequate stability during healing.
What are the primary complications we need to be vigilant about with lunate fractures?
A very significant concern is the risk of avascular necrosis, particularly for displaced volar fragment fractures that are left untreated. This is because approximately 20% of lunates have only a palmar nutrient artery supply, making them highly vulnerable to ischemia if this supply is compromised. Whilst there's no absolute consensus on a direct causal link between acute lunate fractures and Kienbach disease, which is a vascular necrosis of the lunate, any disruption of the critical interosseous blood supply, especially with horizontal fractures, remains a serious concern for progression to AVN. Therefore, persistent wrist pain after a lunate fracture should always prompt an MRI to thoroughly check for avascular necrosis, which is diagnosed by a characteristic homogeneous loss of signal in the entire lunate on MRI scans. Furthermore, any intra-articular extension to the fracture also puts the lunate at an increased risk of developing painful mid-carpal arthritis in the long term.
That has been a truly comprehensive and incredibly insightful deep dive into these less common but incredibly significant carpal fractures. We've traversed the complex anatomy, the subtle presentations, and the nuanced diagnostic and treatment pathways. Professor, once we've successfully diagnosed and treated these fractures, what are the key principles for rehabilitation, and how do we get our patients, especially those active individuals and athletes, back to full function?
Right. The rehabilitation phase is crucial. The initial phase, regardless of the specific carpal bone, typically involves immobilization for around 4 to 6 weeks in a cast or a customized splint. During this critical period, it's absolutely paramount to proactively maintain full range of motion in the adjacent joints: the fingers, the thumb, the elbow, and the shoulder. This active movement helps prevent debilitating stiffness in those uninvolved joints, which can often be a secondary complication of prolonged immobilization.
And what can patients typically expect once that cast or splint finally comes off? It's often not an immediate return to normal, is it?
You're spot on. It's entirely normal for the wrist to feel quite stiff, swollen, and sometimes, paradoxically, even more painful than when it was securely supported in the cast. We advise our patients on regular scheduled pain relief, and importantly, we generally recommend against the routine use of acute anti-inflammatories in the immediate post-immobilization phase. We want to allow that natural inflammatory process to facilitate robust bone healing. Swelling reduction is key. Regular elevation on a pillow, especially at night, and gentle self-massage with a cream or moisturizer, pushing up the forearm towards the elbow, can significantly help to manage both the swelling and any tightness in the forearm muscles.
So once that initial phase of pain and swelling begins to settle, how do we gradually reintroduce movement and strength? What's that phased approach to rehabilitation look like?
We adopt a very structured, phased approach. For early mobility, patients should begin with gentle, active wrist flexion and extension, as well as pronation and supination exercises. They can even use their contralateral, unaffected hand for gentle assistance to encourage movement. Simple hand opening and closing exercises, along with thumb to fingertip movements, performed in sets of 5 to 10 repetitions 3 times daily, are excellent starting points. Ideally, these should be done with the forearm comfortably supported on a table or armchair to minimize strain. As this early mobility improves and pain permits, we progress to strengthening. Typically, around 8 weeks post-injury, once the acute pain is significantly settled, we can introduce light resistance. This can be as simple as using a tin of beans for gentle wrist movements or a soft sponge for grip strengthening exercises. Finally, as strength returns, we gradually progress to gentle weight-bearing activities, such as leaning on a hand on a table, which helps restore full functional load tolerance and prepares the wrist for daily demands.
And for our athletes, especially those who've undergone procedures like hammer hook or pisiform excision, what does the accelerated return to sport protocol typically look like? It's often a crucial consideration for them.
It absolutely is. Excision procedures in particular often facilitate a relatively quicker return to sport, which is a significant advantage for competitive athletes. The primary limiting factor post-excision is typically scar sensitivity, which, whilst it does decrease over time, can sometimes persist for 4 to 6 months. The rehabilitation for athletes is a carefully phased re-engagement. Immediate, gentle hand use, focusing intently on finger range of motion, is encouraged right away. After suture removal, typically around 10 to 14 days post-op, light workouts and grip strengthening with a padded glove, such as a biking glove, are permitted. They can then start getting back into sport-specific movements quite early. For baseball players, for instance, dry swings without actual ball contact can begin. Golfers and racket players can similarly practice swings without striking a ball. Golfers can usually start putting and chipping off a mat around week 3. By weeks 3 to 4, baseball players can progress from hitting off a tee to hitting pitches as tolerated, and racket players can move from light volleying to more powerful ground strokes. Golfers progress from quarter swings to full swings, hitting balls off a mat, and by week 4, they can typically start hitting off the grass.
The overall timeline is quite encouraging. Most athletes can typically return to their specific sport within 4 to 6 weeks, even if some residual scar sensitivity lingers, which it often does.
Professor, that has been an incredibly insightful and practical deep dive into these less common but profoundly significant carpal fractures. To summarize our key takeaways for our listeners, it's clear that maintaining a very high index of clinical suspicion for uncommon carpal fractures is absolutely crucial in everyday practice.
Indeed. And equally vital is the necessity of employing appropriate advanced imaging modalities, whether that's meticulously utilizing specialized X-ray views like the carpal tunnel or reverse oblique, or leveraging the diagnostic power of CT and MRI. These tools are essential for accurate diagnosis, especially when your initial plain radiographs are inconclusive or, worse, misleading.
And once we've achieved that accurate diagnosis, understanding the tailored treatment pathways from conservative immobilization to surgical interventions like pisiformectomy or precise internal fixation is paramount for ensuring the best possible outcome.
Precisely. A deeper understanding of these specific injuries, their often subtle presentations, and their potential complications is not merely academic. It is fundamentally essential for delivering accurate diagnoses, and critically, for achieving optimal long-term functional outcomes for your patients, allowing them to return to their activities without persistent pain or limitation.
As you reflect on your own practice, consider this provocative thought. How many other hidden injuries might be masquerading as simple sprains or nonspecific wrist pain in your everyday cases? What more might we uncover, and what better outcomes might we achieve with a fresh perspective and the right diagnostic tools? If you found this deep dive invaluable, please do take a moment to rate and share our show. It truly helps us reach more medical professionals like you.